Good morning and welcome. Uh, Today, our presenter is Michelle Human, our very own team member. She's a dedicated hematologist at Ampath with strong interest in coagulation and a passion for scientific medicine. She began her academic career at the University of Pretoria, where she completed a Bachelor of Science in Human Physiology, followed by a Bachelor of Medicine and Surgery. Her clinical training included an internship and community service at Tembisa Hospital, where she gained substantial hands-on experience in patient care. Dr. Iman completed her postgraduate training in hematology at Sefako Makgatho Health Sciences University. She remains committed to ongoing professional development and subsequently obtained a distinction in the Principle of Patient Blood Management course presented by the University of the Free State. Thank you, Michelle.
Thank you, Leanne. Okay, so today I'm going to talk about unexplained anemia of aging, also known anemia of the elderly. The reason why I decided to talk about this is anemia has the highest prevalence in the following 5 groups. It's usually children under the age of 5, pregnant women, women of reproductive age, the elderly population, and an HIV population. So because it's one of the top 5 cause of population that anemia arises in, I thought I will talk today about the elderly. So my presentation concerns a lot about this journal. I use this most. It's how to treat anemia in older adults, and I'll add the reference at the end. It's also nice flow diagrams and tables if you do present with an elderly patient with anemia. Then another journal that I used was actually National Institute of Aging had a workshop questioning all the questions about unexplained anemia and aging, and a lot of questions that arise, what to do and how to work up these patients, and also the ethics involved and how far can you actually go to work up these patients to get more knowledge. So it's also interesting to read. So my outline for this presentation is going to be an introduction and the causes of anemia in elderly patients. We all are familiar with that. Clinical consequences, then case discussions. I've got 3 case discussions that I'm going to use in an example, as well as conclusion and references. With my introduction, I just want to say with the global growing older adult population, clinicians face the common yet complex challenge of how to evaluate and manage anemia in this population. Recently, it's been quite viral on social media that the world is actually not ready for the increase in the aging population. It's estimated that the number of people in the world at the age of 60 and older is expected to grow and pass 2 billion by the year 2050. So that's an increase in elderly population. And this is due to the increase in knowledge that's available for everybody, access to medical care, and it increases the survival rate of the units. So with our aging population, we can see that people are actually living longer, but unfortunately, our fertility rate worldwide is decreasing. So this is worldwide seen. This is an interesting data that I gathered just by the more European countries that present with percentage of people of age 65 and older. As you can see, Monaco, there's 35% of their population is actually 65 and older. Japan following with 30%. And this is quite alarming if you can think that is a big chunk of your population that is in your retirement age. And on the 29th of May, there was actually a news brief that they say there's actually a demographic collapse that's actually accelerating. And in Japan, it was known that adult diaper nappy sales has now permanently exceeded the baby diaper sales. So it's actually quite alarming. So they also said that these are the most technically advanced societies on Earth. However, they're actually aging into extinction. As you can see, there's a lot of elderly population and not a lot of children. So this is worrisome. But it's also for our medical staff really important now to focus on these elderly population to keep them up to fittest as possible, because they're going to be involved in the economy for a little bit longer. So from the world data, I then went and got stats from South Africa. And here you can see South Africa's stats. We're actually quite still well underway with our biggest populations being with the working age population of 30 to 34. But as you can see, our older population is actually increasing. So it's quite nice. But South Africa is also following the worldwide. As you can see, our fertility rate has decreased, and it's actually on the decrease rate still. So I think from the previous year, it decreased by 0.9. So it's actually quite alarming. And you can see our estimation of people living above 65 is also increasing according to the stats. So it's quite nice for us. It shows that our education and medical service that we offer is sufficient, but also is this not going to present to us with a bigger problem in the future. So we are following the worldwide stats, maybe just in a slower rate, but we do. And this is just from a stats. As you can see, I've tried to figure out, this was last year's stats of how many people are actually above 60 in South Africa. There's about 6.6 million people that's above 60. So South Africa do follow the worldwide stats. While I was working on this presentation, I actually just paid attention on some of the results I signed out while working on this. And as you can see, it's actually not that uncommon to get elderly population or cases, because this case was 91. The following one was 93. And these are patients, this patient is actually on warfarin. So keep in mind, this is an elderly patient on blood thinning medication. So it's actually also a risk of bleeding. The other patient is a bit older, of 98, and also on warfarin. And the winner goes to from Nels Pad reaching 105. So South Africa is definitely in the world. So even though the aging population is challenging hematologists, but it clearly not everyone slows down with age. And you know, Donald Trump is 80 and he's fighting a war. He's turning 80 next year. So maybe it's not everybody. But okay, so let's go to the presentation. So anemia is a diagnosis in older patients. It's quite a diagnostic conundrum. And the reason for this is because anemia may have a single cause, but it might also be multifactorial. Or there may be no apparent cause after extensive evaluation. Unexplained anemia of aging, it is a common underdiagnosed and understudied chronic condition of aging, which lacks evidence-based and therapeutic options. So that's why a systemic approach to the diagnosis ensures appropriate testing and it avoids pitfalls in the undertreatment or overtreatment of these patients. So as I said, is just with the prevalence, there's in the United States, about 70% of the individuals are above 65. And then also senior adults that's admitted to the hospital, they are more frequently affected by anemia. And the prevalence is even higher in nursing home residents. And also about 10% of death certificates report anemia as a secondary cause of the death. And this is just in the United States. I'm sure in South Africa it's the same. And the World Health Organization defines that women with a hemoglobin less than 12 is classified as anemia, and in men less than 13. So remember these values, because sometimes we do see men or elderly men with an HB of 12. So it's best just to investigate them and keep them at optimal, just to prevent any side effects that can occur with a decrease in hemoglobin. Because with a decrease in hemoglobin, there's still increase in morbidity and mortality and decreased quality of life. We're going to talk about it a bit later. So with the etiological distribution in older adults, usually about 33% or a third, the cause is due to nutritional deficiencies. And these are nice to treat, and it's nice to detect them early because you can prevent any side effects occurring with the anemia. And then also anemia with chronic disease is another third cause. So if you can manage the renal disease or chronic inflammatory state, you can actually improve also the hemoglobin. And then you get the third of the population that is just unexplained. And that is where the question is, what can we do? So as we know, what is the cause of it? So it could be difficult because it could be multifactorial. But I said in older adults, it could be due to hematopoietic stem cell exhaustion, cellular senescence, dysregulating of nutrient sensing. It could also be due to gastrointestinal disorders leading to blood loss or malabsorption. And this could be exaggerated by anticoagulants or antiplatelet therapy that these patients are on. And then also a chronic inflammatory state could also increase your hepcidin and decrease iron absorption. And then to some extent, aging alone. With this aging alone, it also needs to think about the hormone effect. Testosterone decreases in men and women, and it's been shown to actually affect your hemoglobin value. And there's a lot of research being done in menopausal women because estrogen also affects the hemoglobin level. So can't we support these patients hormonally just to increase the hemoglobin? And then this slide we all know, it's just the common causes of anemia. We all know it's iron, vitamin B12, and folate. And then the main culprits causing anemia of chronic disease is usually due to a chronic kidney disease or inflammation. And then also to think about with aging comes this clonal hematopoiesis. It could be due to NDS or CCAS or CHIP. And then it's non-identified, it's just unexplained. So why anemia matters? First of all, it's due to the adverse outcome in elderly patients. They've also seen with a lower HB, it correlates with lower muscle mass. So this will actually decrease physical strength of people. Lower HB has also increased depression and impaired cognition. With the lower muscle mass, there's an increase in fall and hospitalization. There's a decrease in activity, and then overall a decrease in quality of life. So it's also been shown in this journal that even a high-functioning older adult, anemia is associated with a fourfold increase in impaired executive function. So that's actually why we want to try and maintain that AB, that's a hemoglobin level that's functional for the individual. So I've used a few cases just in an example. So case 1, this is an 80-year-old male with a history of hypertension as well as coronary artery disease. He had a non-ST elevation myocardial infarction a year ago. He underwent precutaneous coronary intervention and was on dual antiplatelet therapy and was referred to you for the evaluation of anemia. So he has had an anemia for more than 10 years of a hemoglobin of about 12. He tolerates exercise by bicycling without a change in endurance over the past several years. He denied any gastrointestinal bleeding and has a negative fecal occlude blood test. His G-scope and C-scope 3 years ago showed no active bleeding signs. His colonoscopy only revealed diverticulosis and non-bleeding internal hemorrhoids. So this was his FPC. His FPC, as you can see, his hemoglobin was 12.1. His MCV was within normal range of 93 femtoliter, platelet count also normal, and white cell count normal. His estimated glomerular filtration rate is 55, so it's slightly low, but for his age will fall within normal. And also we'll have to monitor his renal function test. And also if you want to confirm any renal disease, cystatin C is a better test to perform on him. He did not have a nutritional deficiency. As you can see, his vitamin B12 is normal, folate, and his iron. His ferritin also falls within the normal ranges, and his thyroid hormone was actually also normal. So this is just a case of an older adult with a long-standing normochromic anemia with no overt etiology on routine testing. So in these patients, it's important to focus on a history of bleeding to exclude it, also because this patient is on antiplatelet and anticoagulants. There's also other conditions that you should exclude, like inflammation, and also think about cancer and gastrointestinal malabsorption, and also important to ask about the family history of malignancy. They also said that the depth of the anemia and the duration of the anemia is critical in part of your investigation. In this journal, they mentioned in the one sentence that in older age, there's a slow decline of hemoglobin around 1 gram per deciliter over 15 years that can be expected. But unfortunately, they did not state when you can actually supply this and what age you can start expecting this. So they do state it, but there's not actually more information supplied. I thought this is a nice flow diagram just to follow when you do present with a patient with an HB less than 12. I hope it reflects nice. But first of all, you're just going to start with the history and physical exam. Do your full blood count that contains your MCB and as well as your reticulocyte count. And it's important just to exclude the easy causes of anemia, like an iron deficiency, B12, or folate deficiency, and then also exclude hypothyroidism. Because hypothyroidism can increase your MCB and it may mislead you to think of an MDS. It's mainly hypothyroidism. If you exclude those easy causes of anemia that you can treat, you can move over and just do a full iron profile that you would initially with a CRP just to exclude anemia of chronic disease. You can also then do your renal function test to exclude anemia of chronic disease. Also very important, patients that has got chronic disease, if your ferritin is on the low level, make sure that you treat this patient with iron, as a ferritin will be falsely increased in these patients. So it's best to get your ferritin at a level of 300 to 500. And then also rare, but you can in an elderly patient maybe miss a hemoglobinopathy. So you can do a hemoglobinopathy screen just to do a thorough investigation of these patients. If all the other causes are excluded, we go for red flag signs that I'm going to show you on the next slide. If there's any red flag signs, we're going to do a bone marrow biopsy. And then we're going to look for dysplasia as well as bone marrow and do molecular studies just to exclude clonal hematopoiesis like CCAS or MDS. And if all of that is negative, we're going to sit with a diagnosis of unexplained anemia of aging, also known as anemia in elderly. So what are these red flag signs? So the red flag sign has been brought into the workup just to actually protect these elderly patients, not to bone marrow every one of them. But this is for stable mild anemia that we do not recommend a bone marrow biopsy. But if you do see red flag signs, this will be an MCB that's elevated above 96, or additional cytopenias with a neutrophil count less than 1 and a platelet less than 120, any family history of blood cancer, and then obviously any dysplasia or blast that you detected on peripheral smear. A severe hemoglobin of less than 9, it's actually important then to investigate the scores, and then worsening unexplained anemia. If you have any of these signs, a bone marrow aspirate is then suggested as part of workup. And I just wanted to show this flow diagram, or actually where everything of clonal hematopoiesis fits into place. So first of all, you'll diagnose MDS if the criteria for MDS is met. Otherwise, there's a bit of an overlap with CCAS. And then you see idiopathic cytopenia of undetermined significance, where unexplained anemia overlines that. And I'm going to talk a little bit more about that. So as we know, MDS is usually when we do get a lot of dysplasia, more than 10% of one of the cell lines, or if you look on the bone marrow, you get 15% ring sideroblasts, or an increase in blasts, but less than 20%, and then also genetically defined abnormal chromosomal abnormalities. And then CCAS is where you just get a somatic mutation over 2%, but it does not meet the criteria of MDS. And idiopathic cytopenia of undetermined significance is where there's a very small mutation detected less than 2%. And then if you just get an isolated mild anemia in an older patient with no red flags, and if the investigation was done with no molecular disease, they usually say that you can label this patient as unexplained anemia of aging. So like I mentioned now, I did actually discuss this slide. MDS will be met if the diagnostic criteria is met. And in these patients, if they have anemia and it does not meet the MDS diagnostic criteria, but has somatic mutations associated with hematological malignancies on cytogenetic, FISH, or MDS, the diagnosis will be consistent with CCAS if the allele frequency is more than 2%, and ICAS if it's less than 2%. But there is an overlap, like I showed, and I did mention this, that will favor unexplained anemia of aging. If the patient have an isolated mild anemia, usually less than 2 grams below the mean, and then and if the bone marrow was performed, no suspicious findings were detected on bone marrow, as well as on molecular studies. So in this case was diagnosed with unexplained anemia after all the other causes of anemia were excluded. And this was in the second journal that I just had a workshop that they had where they actually said they put in a flow diagram, and it's a question if unexplained anemia, if it actually occurs before the ICAS and CHIP. So it's also just a research question that they're still evaluating, but this could be in the process of the clonal hematopoiesis that's following. So how do we manage unexplained anemia of aging? So they have studied intravenous iron in treatment for patients, and they've seen that on a randomized controlled trial that if they gave patients or with patients with a ferritin of 20 to 200, and they treated with a 5-week course of IV iron sucrose, so they gave this patient an IV treatment, there was a small but statistically increase in hemoglobin. You can say about a half a gram per deciliter that increased about 12 weeks. So according to them, they said that IV treatment is actually quite sufficient in these patients to increase the hemoglobin level. So because and the educational point of this is they say that the cause of this anemia in about a third of these cases in older patients is usually by diagnosis of exclusion. And the pathogenesis is unclear and is possibly driven by multiple age-related changes. Anemia of unexplained aging is usually mild, and we recommend observation without bone marrow testing. So if you do have a patient, I'll suggest that you then treat with, as they suggest in this journal, with intravenous iron therapy, monitor the patient annually for FBC, and look if the HB is actually dropping, exclude any bleeding history, counsel the patient, because if they are on anticoagulant therapy, to report to the hospital when there's an episode of bleeding. And then yearly follow-up in these patients is sufficient. So this is just a table again, just how you could investigate and the actually end marks that I would suggest for these patients. So case 2 is a 68-year-old woman with a history of type 2 diabetes mellitus. She's got hypertension, coronary artery disease, on aspirin. She had a repaired abdominal aortic aneurysm. She's also known with hyperlipidemia and osteoporosis, and was referred to you for evaluation of anemia. She's also been a vegan for 3 years. The physician initiated oral iron sulfate of 65 milligram of elemental iron, so this one tablet daily, and she denied also any other cravings for ice. She denied fatigue, but had reduced endurance evident by new requirement of rest after a short walk. She had been transfused only once in her life, and this was during an aneurysm repair 10 years ago. She's got no family history of blood cancers. So these are her laboratory tests. 2 years ago, her hemoglobin was 13.5 with an MCV that was normal. And now recently, when they started investigating her, they could see that the hemoglobin dropped 11.3. The MCV also dropped a bit. And the serum iron, you can see, is now low, 25 micrograms per deciliter, with a saturation of 7%. That's also low. And the ferritin, as you can see, is 25. So even though the laboratories will give you a reference range, that is on the borderline low area, that we actually would classify this patient as an iron deficiency. They also did a fecal occlude blood test, and that was positive on 3 parts. So this patient's got an iron deficiency and signs of bleeding. So this patient was actually diagnosed with iron deficiency, who's been on oral iron for 2 years, but she does not show a sufficient response. So what to think about is the considerations to think either if she's got ineffective oral therapy for the iron deficiency, is the bleeding actually in excess for the iron repletion? Is there maybe non-adherence, especially in the settings of intolerance and malabsorption? Usually the elderly patient complain a lot about diarrhea or gastro or just stomach cramps. Or is it just insufficient dosing for this patient? So with endoscopic evaluation, irrespective of the fecal occlude blood test, is indicated in a patient with iron deficiency, and this is just to exclude any malignancies, even if an iron deficiency is established. So patients with iron deficiency may present with microscopic, but most of them may have normochromic hypertrophic red blood cells. As we saw in this patient, the MCV was actually normal. And nearly 70% of adults over the age of 65 may present with a normal MCV. It's also important, patients that are on chronic iron therapy, is to counsel the patient and also do a fasted state or to stop the iron therapy before iron studies is actually collected to assessed again. With the saturation less than 20, it shows that the iron supply is not adequate for the red blood cell production. And a very low saturation of 15% is actually consistent with an iron deficiency if you interpret it with the entire whole iron studies. So this patient had a ferritin of less than 50, and this is suspicious for an iron deficiency in all the patients. Intermediate ferritin levels that range between 30 and 100 pose difficulties, particularly in the elderly population, in view of the chronic diseases. Like I mentioned, ferritin levels increase in these populations, and it can actually increase more in chronic heart failure and inflammatory disorder. And so we want actually in this case a ferritin levels of up to 100 or even 300 with chronic inflammatory states. So with this patient, it is best actually then to reassess the treatment of her. We can replete the iron using oral iron formulations because usually they contain 50 to 65 milligram of iron. But in an older patient, due to the side effects, you can decrease the iron content of the tablets. They showed actually with lower dose of iron that contain 50 milligram compared to a higher, that you can give an alternative days could also increase the hemoglobin level. However, it is best if you want a fast response to give an IV iron drip to actually increase the hemoglobin. This will actually also decrease the malabsorption condition that patients have if there's a history of gastric bypass. So the patient was given dextran drip, and her walking endurance improved, and she actually achieved a normal hemoglobin level. She also then continued on ferrous sulfate on every second day or alternative day, because she's also on aspirin for secondary prevention for coronary artery disease. So in this patient, they actually just increased the hemoglobin, monitored her bleeding, and also tried to counsel her for any other diseases. And they did take her for G-scope and C-scope and exclude any malignancies in her. And then they just want to maintain the hemoglobin at a stable state to increase actually her quality of life with the hemoglobin maintained sufficient for her. Then on case 3, so this is a 75-year-old woman with stage 3 kidney disease. She had a gastric bypass 20 years ago. She's also known with hyperlipidemia and rheumatoid arthritis on daily low prednisone or low dose of prednisone, and she was referred for evaluation of anemia. Her weight is 64 kgs, and she's been on compounded multivitamin and B12 injections from a bariatric team, and she reports fatigue. So this is her FBC or laboratory test. As you can see, her hemoglobin is 8.4 with an MCB that's quite elevated, and the peripheral blood showed macrocytosis. Her vitamin B level is quite high, but keep in mind she is getting injections. Her ferritin is 50. So in a patient that's got rheumatoid arthritis, chronic kidney disease, this is actually quite low for what you want for a patient in this chronic state. As you can see, our iron is within the normal level, and the saturation is 20%. The thyroid stimulating level was within normal levels, copper was normal, and as you can see, she is known with chronic renal disease with a glomerular filtration rate of 20. The CRP is also raised that we could think about because of inflammatory diseases, and the erratic EPO level was slightly elevated. So this could be due to a stunted bone marrow response due to EPO, and they did do a bone marrow investigation in this patient, and they detected that there's actually a normal cellular bone marrow response, and they also did all the molecular investigation. There was no molecular abnormality detected in this patient. So the vitamin B in this patient was probably high because of the treatment. She's got an concomitant iron deficiency, and then the macrocytosis could actually just be due to an increase in reticulocyte production of the marrow that they picked up on the FBC. So this case had actually a multifactorial anemia. First of all, it could be an iron deficiency or iron restricted erythropoiesis of malabsorption, or anemia of chronic disease, or anemia of chronic inflammation due to rheumatoid arthritis. There was an CRP that we did detect in the studies. And then anemia of chronic disease is actually common in elderly patients with multiple chronic infections. And like I see, there was probably erythropoiesis block. And she's got a concurrent chronic kidney disease. So there's also a decrease in hemoglobin with glomerular filtration rate that decreases. And this is caused by a reduction in the EPO. And it could also be due to a reduction in hemopoietic response to EPO, as well as remember that uremic toxins within the blood affects your platelets, could increase the risk of bleeding. That could all contribute to this patient to a decrease in hemoglobin. In older adults with inflammation and chronic kidney disease, like I mentioned, ferritin levels indicate iron-restricted anemia, but less than 100 is usually indicative of iron deficiency. And this patient is actually a best candidate for iron therapy. Because the patient had a history of bariatric surgery, of anemia of chronic inflammation and anemia of chronic kidney disease, they continued with the nutritional optimization of vitamin B12 injections and started on IV iron therapy. And to maintain her ferritin between 300 and 500 nanograms per mole. And they want to also, they actually, in her case, deferred EPO. As you can see, the EPO level was a little bit high because they felt that her hemoglobin was stable at 9.5. And if you remember the table that I showed you in the beginning there, they said that EPO is actually suggested in people with an HP less than 10. So I think you have to take and consider each patient for itself. You will give EPO in patients to level up the hemoglobin above 10, but you do not want the hemoglobin in patients with cardiac disease to go above 11, because then it could have any other cardiac side effects. So I think it's a narrow way of monitoring your patient to get their optimal hemoglobin level. In this patient, the symptoms of fatigue and exercise tolerability actually improved in the last case. So just in conclusion, this presentation I actually just used just to supply everybody with a systemic approach to evaluation and the management of anemia. This will ensure appropriate care and may optimize hemoglobin and potentially ameliorate anemia-related morbidity while minimizing unnecessary testing. This is actually a topic of research in the field of medicine, and this is because anemia in older age has no discernible cause or proven therapy. And also there's a major ethics role in actually how far do you want to investigate the elderly population. If it's ethically allowed, will you do a marrow on all these patients to assess hemopoietic reserve? So this is the study of research, and every patient would be treated optimally by itself to increase the hemoglobin level to improve the quality of life. So this is my references, and this is the end. Thank you.
Thank you, Michelle. This is really quite a very nice presentation. And I mean, it's a seasonal topic that we see on a daily basis, that actually when you as a physician still pass in midstream, our hospital is surrounded by a lot of I'm in home. And our population, I mean, I remember last month, our average age was about 75 in ICU. So we see that on the daily basis, really. And I mean, we have a patient resident with MDS, actually, she was 78, which got a lot of transfusion. Hemoglobin, the iron was almost about 3,000 because of the iron overload. So we quite see a lot of them on a daily basis. And the question that sometimes based on our training as a medical doctor, when you're about 60, and especially when you cross 80, you're ignored because they think you're too old. But the reality is that actually one thing which I highlight, I mean, if you look at Japan, you look at most countries, the expected life is almost 90. I mean, midstream also seeing a lot of 90, 91, 92. So if you look at we sitting in this room, most of us probably going to live up to age of about 100 or 110, because now the new 80 will be 90. When you're 90, you feel like you're 80, not longer 65. So I think it's a very good topic to discuss. So regarding your case two for me, it's a 65. She was quite young, but she got all the vasculopathy. She was what you call classic vasculopathy. And there's quite very strong association between vasculopathy and what you call angiodysplasia in the colon. So most of these patients actually come present with the silent anemia, that most of the time all your workup is actually negative until you do what you call video capsule cellaring. That's when you actually see the angiodysplasia. And that's basically angiodysplasia is where your blood vessels, where there's air weakness in your colon, and they bleed from that. And that's more related to this patient. They tend to have previous cabbage, aortic stenosis, and a bit of dyslipidemia. So I think it's something that I think we need to consider, not to marrow every patient. I think that's very important, but also, I mean, Mara probably Leanne will tell you, she did a presentation on osteoporosis. Most of these patients from underlying osteoporosis, and during your marrow, you might cause traction. So it's very important that, we have to have an insight into those kind of presentations and see what's really happening. Yeah. So
just to add on to case 2, it was a normocytic anemia that she got. She was on a vegan diet. There was no mention of the vitamin B12 levels, because it is potentially something, if you have a vitamin B12 deficiency in conjunction with the iron deficiency, that you can get a normal MCV. So that's just one thing to consider.
I've got 3 things. So first of all, I think your first case. So the one thing that just stood out for me is the treatment for that. Now, first of all, IV iron is quite expensive. Now, in a patient where everything is negative, the patient is asymptomatic. Now, I probably wouldn't give IV iron to increase the hemoglobin by 0.5. Yeah. And I don't think medical aids probably will pay for it. So once again, I think if your patient is stable and there's nothing, I think you can probably sit on the patient and just follow the hemoglobin up every 3 to 6 months. Then the other thing I think is also in the elder population, probably 90% of them are on PPIs, and I think that also affects the absorption of iron and all those kind of things. And the third thing is just all your cases, it's like patients that you probably see on an outpatient basis. I think the challenge comes in when patients come in, they're septic, they've got active disease. Now they're coming with an HB with high ferritin. So you don't know, is this acute phase? Is this something that's been going on? So I think that is probably where the challenge is. So how long after discharge should you follow them up again, retest their?
I think it will be the same as with when you start giving iron therapy, probably 3 months to see if sufficient. Actually, in 2 weeks, you can do the reticulocyte count. But in these patients, that's actually stable or rather do it 6 months. But in the journal, they say to actually monitor them annually, not to over-investigating.
I
But
think that's
obviously,
I think
if
that's
the
especially with over investigation, especially in person that's stable. Now, if they don't have any symptoms, I think you can probably sit tight on it.
Problem is just to identify who's non-compliant with the oral iron and constipation.
I think in these cases, they actually, I don't know if the journal wanted to motivate that it's safe to use IV iron therapy. I think that's maybe what they wanted to say. And then some people don't respond well on oral iron and think about iron.
The problem is those journals are international journals. They come from South Africa. They don't understand the challenges we face, in getting IV iron.
Also, I think that, it's a typical that this is the patients which are the tea and toast studies. So the older you get, you're not going to eat a big 250-gram piece of steak twice a week. So and there's and isn't there something with the tea with absorption of with the iron as well?
Decreased absorption.
Me, I'm gonna be eating 500-gram steak. I'm gonna be tough old man.
But I also think it's important if you do get elderly patients to actually also do nutritional studies, even though the HP is mild and MCB looks normal, just to prevent the job.
Dr. Kohli online, you're based in Secunda, a lot of elderly population. What's your insight into anemia? You see quite a lot of them there, anemia of aging. Okay, I think I left the line.
What is there like an exclamation mark?
Did you meet him? Dr. Kohli?
I think he's got a problem with.
Hello?
Mike.
Oh,
Hi, Dr. Kohli.
Yeah, good morning. Thanks, Michelle, for the presentation. No, it's a common presentation, and a lot of them from the blood thinners, some from nutritional, some from GI bleeding. So just try to do the workup and then manage accordingly. Yeah, sometimes you end up not seeing anything. I know a couple of people that we even ended up with capsule endoscopy, and we ended up not seeing any, even on bone marrow. So just continue with the chronic replacement therapy.
Yeah. No, thank you. Yeah, I think we see quite a lot. I think you did mention that it's actually multifactorial. Yes, that's why you have to look for it. And the next thing is that whether does it worth doing all these expensive tests, because the majority of doctors get discouraged when you're above 80. They just don't want to do much. But the truth is that actually I always say that as long as I pay for my medical aid, I deserve the best. So don't stop investigating me, but don't give me bone marrow either. Thank you.
Another thing I want to mention is if you're worried and you communicate with your patient as elderly, you can always do, if you don't want to do a marrow, you can do myeloid NGS on the peripheral blood.
Oh.
But the problem is if you do detect something abnormal, then you'll need to do a marrow. So it's something that you'll have to discuss with the patient itself.
But let's be honest, Michelle.
Yeah.
If you diagnose me with MDS, what can you do for me apart from the constant transfusion?
I can do that.
Okay, great. Here we go. Yeah. All right, Dr. George, I'm getting for bone marrow because you can do much for MDS.
He is not.
All right. I'll take that on back. Thank you, guys, and appreciate it. If there's no question,